Thank you very much, Lucas, Eduardo. It really is an honour to be speaking with Nathan Cherney and Kathy Foley today. Kathy, we may have to make you an honorary Australian. The Australian football is currently on, and I think Nathan is following the scores. The Ryder Golf is on, so I'm really delighted that lots of you are here. David Kerr is really a champion of mine, but I'm in awe of this Oxford Don who does all this stuff. But last year I was with him in Malaysia, and he slipped in the word cure. He talks about all these drugs, and he slipped in the word cure. And we had a little talk about that. And I'm just going to re-explore that issue of what we're really doing in oncology that David raised. We so often use the language, if it's not palliative, it's curative. But what do we really cure in oncology? Is this language we should be using? This is just a survival curve, and this is to set the theme overall of the importance of palliative care. Just to remind you that even in the United States, 100% of people die. But a normal population curve and a disease. A disease is curable if people with that disease die of something else. A disease is curable, not individuals, a disease. Much of what we do in oncology is prolonging survival, and it may be years in adjuvant breast cancer. It may actually be weeks in pancreatic cancer, non-small cell lung cancer. But again, palliation is, in fact, I would argue, much of what we do in oncology. And we've forgotten that. UICC has not forgotten this, and I think it's very important when we see what UICC talks about, the prevention, the early detection, early treatment, but the palliation, 1/3, 1/3, 1/3. But we so often sit in these rooms and forget the reality. So let's share the reality of someone experiencing cancer.
Here, in the rural outskirts of Calcutta, India, top-notch medical care is hard to come by. But Dr. Abhijit Dam makes do. The day we met him, he had transformed this school courtyard into a makeshift clinic and virtual pharmacy, dispensing drugs for a variety of ailments. But when he heard reports of a woman dying of breast cancer in a neighboring village, Dr. Dam knew he was in for a challenge. The woman, named Fatima, had a massive breast tumor, clearly infected and clearly painful.
She has severe pain, she can't sleep at night.
Fatima's family says she screams in agony day and night. But because of strict narcotics laws, morphine, the gold standard in pain treatment, is nearly impossible to get in most of India. So Dr. Dam is forced to improvise with readily available analgesics.
This is really difficult to watch, and it's particularly difficult considering that, with a 2 rupee medication, she would not be screaming.
And Human Rights Watch has really put a focus on this. Their report, Unbearable Pain, India's obligation to ensure palliative care, and there are many now working in India to ensure this. But a recent publication or press article in the Times of India highlights this problem. USA, Canada consuming approximately 75 milligrams of morphine per person. India, less than 0.1 milligrams per person of morphine a year. And India is one of the major producers of morphine, as we heard. And we can look at this in other ways. These graphical interfaces with Sri Lanka, India and Bangladesh. The Bhutan is actually at 4 milligrams per person per year. If we take this into a global perspective, though, and where does India fit here? Almost not registering on the global map. Austria doing very well, but Austria ranks higher because it uses morphine for substitution therapy for the treatment of addiction or dependency syndrome. But the global mean is 6 milligrams per person per year, and here we have countries such as India, less than 0.1 milligram per person per year. Eduardo mentioned some of these figures. 91% of the world's 17% of the world's population consuming 91% of the world's morphine. And we can look at this even more recently for 2010, the high-income countries consuming most of the world's morphine, the latest data from the International Narcotics Control Board. We work very closely with the International Narcotics Control Board. They publish this data, but they actually exclude in their public reports any amounts less than 500 milligrams in these reports. Through this, 500 grams, we're actually able to include any of this data, and this is all available on our website. How is this done? Countries actually report to the INCB what they're consuming, and this is now being used as an indicator for its ability to manage moderate or severe pain. And as Eduardo mentioned as well, the WHO is now using this as an indicator in the fight against non-communicable diseases. How can we actually improve these efforts? There's limitations. If a country doesn't report, we don't know about it. We can't distinguish how it's being used. For instance, the example with Austria. Is it pain? Is it dependency syndrome that morphine's being used? It doesn't tell us whether it's being used for acute or chronic pain. And it only really gives us a partial view. Are there enough clinicians to actually write and prescribe? What's the supply mechanism? These are the issues we need to address. And it's not just about morphine, there are many other opioids. And this is a new metric that we're using, which is morphine equivalence. With the WHO Centre in Drug Equivalence in Norway, we're actually able to calculate and bring everything back to morphine equivalence. So morphine is here in the blue down the bottom, and I can get an arrow here. But we can see the general world consumption of opioids, and this includes fentanyl, oxycodone, and other opioids, has been rising. But most of that rise is in high-income countries with almost no increase at all in low to middle-income countries. Why is this? Since 1961, here, the World Health Organization, the UN, established a single convention on narcotic drugs. It establishes a framework to prevent abuse and diversion and, this is not a but, and ensure the availability of drugs for medical purposes. The medical use of narcotic drugs continues to be indispensable for the relief of pain. Adequate provision must be made to ensure the availability of narcotic drugs for such purposes. So this comes to the principle of balance. Should establish a drug control system that prevents diversion and ensures adequate availability. Drug control measures should not interfere with the medical access to opioids. WHO has been working on this, and Kathy Foley involved in the original 1986 report, Cancer Pain Relief. Again, 1996, we saw further reports. But then we continue to see, INCB did this. 65 countries surveyed. What are the impediments? Fear of addiction, lack of training, laws, fear of legal consequences, not enough opioids, the cost, inadequate healthcare resources, and lack of national policy guidelines. To overcome this, in 2000, the guidelines from WHO achieving balance in national opioids controls were established. And these have been put out and published now in many languages. But again, the barriers continued. The World Palliative Care Alliance, Help the Hospices, published this in 2006, a survey in Asia, Africa, and Latin America. What are the barriers? Strict national drug laws, fear of addiction, poorly developed healthcare systems, and lack of knowledge. The essential medicines, and this is 2010 list, says that codeine and morphine are essential drugs. But many countries don't actually have them on their formulary, despite them being on essential drugs. The International Association of Hospice and Palliative Care a number of years ago hosted a meeting with WHO in Salzburg to look at which opioids should be included on the essential drug list. And these were the opioids that they actually said: codeine, fentanyl, methadone, morphine, oxycodone, and tramadol. But importantly, there's a yellow box warning. Countries shouldn't have these sustained release opioids until they ensure the access to immediate release opioids. And IHAPC will be working and collaborating potentially in the near future with the WHO to improve this essential drugs medicine list. Again, we talked about the Achieving Balance guidelines and more recently, Ensuring Balance in National Policies and Controlled Substances has been released, an update from the WHO to ensure all these. And these are now available in many, many languages online. I encourage you to go online. Here's the website to look at this. You can actually, the best way I find to find it, Google the words Ensuring Balance opioids rather than remembering the web address, which is much too long. But in the Vic Centre, just adjacent to us in 2010, the Commission on Narcotic Drugs in their meeting passed a resolution. A dual obligation of governments to establish a system of control ensures the adequate availability of controlled substances while preventing abuse diversion. Controlled medicines are essential and absolutely necessary for relief of pain. These are the drug police talking. These are the controllers meeting here in Vienna. To ensure the rational use of these medicines, governments should both enable and empower healthcare professionals to prescribe, dispense and administer them. While misuse is a risk to society, the system of control is not intended to be a barrier to their availability for medical and scientific purposes, nor interfere in their legitimate medical use for patient care. So we've got lots of barriers. The regulatory system, the drug distribution system, the cost, and the knowledge and attitudes of physicians, clinicians. Other people have looked at these consumption of opioids in different ways, and this is work by the World Palliative Care Alliance looking at opioid. This is morphine access by countries around the world. And we can actually see that the red is where consumption gets very, very low, less than 0.033 milligrams per person per year. Huge parts of the world not having access to opioids. They've also gone and looked at palliative care development in different countries around the world, and we can see how much the development of palliative care mirrors the actual morphine availability. I'm just going to try and show you this graphic if we can. This is from Gapminder, which many of you may actually be aware of. And you'll hear me clicking. But what we have on the y-axis here is morphine consumption, and I have GDP. The countries, that one there is the United States. Countries in green are Europe. For you, Eduardo, AMRO is the light blue. African countries are dark blue. But this is actually morphine consumption per GDP. And we can take that from a linear aspect to a log, and we suddenly see where all the blue countries were. India is the large country in yellow circle. We can go from GDP to the Human Development Index, and again show that it seems that the whole relationship of these findings is that opioid access is something that you get when you have high human development. We've now switched this to morphine equivalents, which includes oxycodone, fentanyl and other opioids. And we're going to follow this now with time. And I encourage you to go and play with this on our website. It's well worthwhile looking at. Again, stressing that this is a log axis. And as you follow this with time, I've put in here Australia. And we can click on a few others. We can start following Argentina. Again, a log axis. But you can look at your opioid consumption as you go through. Brazil, Cambodia, very, very low. But we can map and mirror the low consumption of all the different opioids that are provided to us by region and by country. And I just put this up here because, in fact, I always worry that the graphic won't work. And you can see different countries. And I've moved this now from the GDP on the linear scale. But why are some countries such as Qatar, Singapore, very high income countries, still very low consumption? And these are the poorer countries of the world in terms of GDP, older figures but really unchanged. India with 17% of the world's population. We can see the remarkable contrast between the high and the low income countries in terms of opioid access. And here's the Human Development Index. Another way of showing this is work done by the Global Task Force of Cancer Control out of Harvard. And what they did in this was look at a number of parameters: cervical cancer, all cancers in children, breast cancer, and what is called the non-methadone opioid consumption, measured as per death from HIV or cancer. And what they found was greatest difference in the cancer control setting. Here we have a 12-fold difference in cervical cancer mortality from the top 10 to the bottom 10 countries. We've got a 4-fold difference here for cancers in children, the mortality. Breast cancer, 3-fold difference. But look at this difference in non-methadone opioid consumption. A huge, huge difference between the high and low income countries. You've heard about this work previously. And what you're going to hear from Nathan Cherney is an update on this. But the formulary availability, which was done in collaboration with ESMO and EAPC when Lucas was president of EAPC. And this was based on the huge disparity between the East and the West in terms of morphine consumption in Europe. He went through, and he'll be explaining more of these slides. Here we have great availability in Western Europe, and we have very little availability of opioids in Eastern Europe. But particularly we have countries that have no immediate release morphine, and we have one country, the Ukraine, that at the time of this survey only had injectable morphine available. And I'm going to show you an example of that situation.
People in more than half the countries around the globe have limited access to medical morphine, and of that number, more than half face severe shortages of pain medication. Here in Ukraine, some of the same bureaucratic hurdles that plague India mean that even a former decorated KGB colonel is left to die in pain. Artur Shumanov has stage 4 prostate cancer and is living out the end of his life alone and suffering.
Ой, я кричу ночью здесь.
It got so bad, he says, he's left his family in Kiev and moved to this cottage in a remote village hours from the capital.
Я не хочу, чтобы они видели, как я плачу. От боли.
The undertreatment of pain is a huge, huge issue. In Ukraine, pain is part of life. We can see the mark what the radiotherapy was given.
We invited Dr. James Cleary, a leading authority on global palliative care, to join us of the scope of the problem here.
Because of his pain, he's cut himself off from his family. What greater time is there for a man to need his family than when he's facing advanced disease? But what did he say? He didn't want them to see him cry.
Artur has found his own way to numb his agony.
И так каждый день бутылка.
And if it gets bad enough, Artur showed us his other plan to stop the pain.
Я чтобы остановиться, когда будет сильно больно.
To watch Arturo reach under his pillow as he's talking about potentially ending his own life and then just pulling out this gun. This is not a gun in a cupboard. This is a gun that he sleeps on. So clearly the impact of this severe pain is great if he's that close most of the time. Improving cancer pain management is a target for many, including UICC, and it's a 2020 target. And to do it, it has established a program called GAPRI, Global Access to Pain Relief Initiative. And this is a slide that Meg O'Brien, the director of that program, has provided, which shows where many of the problems can occur. The competent authorities involved, INCB's involved, confirming orders. We don't have quotas. You ask for it, generally INCB will give it to you. The government then has to get it around, it has to get distributed, it's got to get to patients. Patients have to fill that prescription, and in any one of these processes it can break down. We need a system that has drug availability, education of clinicians and policy so that we overcome these breakdowns. And this is certainly a difficult fight because of the issues that come up in the politics, fear of addiction, the regulatory barriers and the scrutiny. But just yesterday, this story from the Financial Times, again indicating that millions of people across the world lack access to pain control. We as a society, as medical oncologists, I feel are obligated to address this issue. And Nathan Cherney is going to be providing us with significant data to help us on this process. But it's not just a professional obligation, it's a personal obligation. It's an obligation for people like Arturo. Thank you very much.